Hormone Day. Don't be nervous, don't be anxious. It's really about big connections. And if I had to pick one goal for the day, it's by the end of the day, you understand how other issues in the matrix, other nodes of the matrix, can cause hormone imbalance, and how a primary hormone imbalance can impact other areas of the matrix. That's really the big picture goal, and there's a lot of slides here today. It's a lot of great speakers, and you'll then be able to go and listen again, because we don't expect you to grok this all after one try. It took me many hours to really understand this. And then, if you're ready for certification or ready to learn more, there's the advanced practice module in hormone health. So, we are going to explain how hormones fit into this heuristic, this overlying stepwise approach to managing patients through a functional medicine lens, but specifically with the frames of hormones. So we thought hormones were complicated. And when we say complicated, complicated is something that you have to really spend a lot of time to understand. And once you understand it, then it's easy to figure out what to do. That's complicated. So through that perspective, hormones are messengers of communication. That's why we call ourselves the communication node. And this is the same kind of language in the conventional medical texts, because that's what allows the organ to interact with the environment, or the organism rather, through changing the way different organs work. And when they change the way they work, it's because metabolism changes. We make more compounds or we eliminate more compounds. And then we interact. All the organ systems interact. We interact with each other, fight or flight. Maybe we'll avoid something that we fear, or we interact and we have to fight. And that's how we adapt to our environment. But unfortunately, the more we dig into how hormones work, we realize it's not just that they're complicated, where you can come up with an easy answer, because the fix for hypothyroidism may not just be synthroid. Maybe it's looking for some of the root causes of hypothyroidism, addressing those root causes, and then it's less synthroid and sometimes no synthroid at all. And it's different for each patient, and that's what makes it complex. Meaning there's not a same answer for every problem. There's no algorithm. And the endocrine system, hypothalamic, pituitary, adrenal, thyroid, and gonadal axis, is complex because many of these glands or organs function in different ways. And this forces us sometimes, when someone's coming in, to think how hormones work in relation to the specific thing that they're concerned about. So is it a hypothalamic issue? Is stress involved here? Or a pituitary issue? Or is it thyroid? Or thymus? Or pancreas? Or is it the adrenals that sit on top of the kidney? Or is it the gonads, the ovaries, or the testes? These are the glands, and we can have issues with one or more of those particular glands that can all create what we call a hormonal soup. We used to have a slide that resembled a Campbell's soup can. And it really is a hormonal soup. That's the hormonal milieu in the body. And not only are the hormones in varying different amounts, and not only do the hormones get secreted or produced in relation to other hormones, But what's important is also how they're carried around the body, right? So steroid hormones in general are lipophilic. But in order to get to their distant organ, or where they may function, we have to do hormone transport, has to be hydrophilic. So that's because the bloodstream's made of water, and that happens through sex hormone binding globulin. And the variations of sex hormone binding globulin concentration affect hormones. So low sex hormone binding globulin means more free hormone, which is increased hormonal effect. And for example, that can cause a problem if we're worried about estrogen and breast cancer risk, or estrogen and breast cancer. So low SHBG would be a problem there. Half-life is important. Half-life is important because when we're giving hormone replacement, for example, when we're giving T4 with a 7-day half-life, we can dose every day and it's not a problem. But T3, which has a 1-day half-life, we have to give twice or 3 times a day. Now, we all have an individual way that we take care of our patients. And sometimes I find I can get away with a little T4 or T3 combined in the morning and maybe just a T3 booster in the afternoon. But you'll learn about that. So there's variation. Why? Because hormones are complex. And of course, there's variable distribution of hormones, which makes sense when we're talking physiology and becomes confusing as can be when we're talking about laboratory testing. Because what do you measure and where do you measure? And of course, hormones vary both time of day, time of month, within the same person, and within different people. So if we're looking at, for example, day 21 progesterone levels, we take cycling women, there's going to be variation there. But within the same woman, there'll be variation month to month. So not only is it hard to find the tissue to measure, when you do the measurement, you have to understand that there's variation. So hormones are complex. And what's normal changes over a lifetime. Testosterone normally decreases. DHEA normally decreases. So then we have to figure out as a practitioner, what's our goal? We want to bring hormone levels back in our 50-year-old patient to what they were when they were 30. These are questions that have to be answered. The body tries to create balance. It tries to correct whatever problems there are, either in the environment or within, and it does that through homeostasis. And with hormones, we then end up with sometimes excess and sometimes deficiency. And the challenge for us is to figure out when that hormonal imbalance, that hormonal excess or deficiency, is something that is due to a root cause that's fixable. So maybe our thyroid hormone is low because we don't have the nutrients for thyroid function. Maybe we've got too much insulin for a reason, and you heard about this already, right? Maybe there's inflammation or rigid cell membranes, and so the insulin can't bind, and if the insulin can't bind to the cell membrane, we can't get glucose into the cell, and if we can't get glucose into the cell, the glucose number in the body is elevated. And so when the body senses that glucose is elevated, it does what it's supposed to do, which is make insulin. So it produces more insulin. So the reason the body's producing more insulin, either in Met syndrome or type 2 diabetes, is an appropriate reaction to elevated glucose in the blood. And hormones are deficient, as I said, if the thyroid's underactive. What about hormone resistance? So this is an interesting concept. It's a lot less common, but it's out there. So there can be resistance to cortisol, for example. And that can be a genetic problem where cortisol receptors are blocked. We can have hormone resistance with the thyroid as well. And you'll learn about how to find all of these different things. And then hormones are secreted rhythmically when everything is working properly. But you can have, because it usually starts in the hypothalamus, and when we're talking about those internal brain structures, those are the first areas that are susceptible to stress or nutritional issues. You can then not have the pulsatile secretion of these hypothalamic hormones, FSG and RH, from the hypothalamus, and then the pituitary doesn't get the right message, and ovulation doesn't occur. So remember the matrix. And the reason this slide is here is to reinforce this concept that imbalances in the matrix affect hormones, and hormones can cause, or hormonal issues can cause imbalances in the matrix. So this is not meant to overwhelm you, but again, this is the big picture piece. So when we're talking about the communication node, we see that everything within the communication node can impact other hormones in the communication node. And you're going to be learning this in a very systematic fashion as we break down the day into the different main sections of hormones. And I want you to understand how giving one hormone can change another hormone, not always for the bad, right? So sometimes, if we remember, like we came up with this, what we call the hormonal hierarchy of adrenal, thyroid, and then sex hormone. Because if you work on adrenal issues, sometimes the thyroid issues improve or even go away, and then the issues with sex hormones can go away. So if you're suffering from hot flashes, for example, and there are issues with the adrenal, by fixing and addressing the adrenal, the issues with sex hormones go away and you don't have to give estrogen. So let's talk about how hormones interact. So there's one category is synergistic. So that means both are required, and when you have both, you get maximal effect. So if we're talking about testicular sperm production, there's FSH and testosterone are both needed for optimal sperm production. Permissive. This is the way I like to think of permissive, is it's one hormone gives another hormone permission to do its thing. So the best example of that, or one of the good examples of this, is thyroid hormone. So when enough thyroid hormone is present, then epinephrine, which is a sympathetic driver, is allowed to do its work and can interact with its receptors. So this is one of the lesser known ways of hypothyroidism leading to low energy or fatigue, because it actually impacts how epinephrine can be effective. Then there are the classic antagonistic effects that we all learn about in our training, about insulin and glucagon, lowering blood sugar, increasing blood sugar, parathyroid hormone and calcitonin, raising blood calcium and lower blood calcium. Interactive effects. We all know about calcitriol, synthetic form of vitamin D, and parathyroid hormone, how when we have low parathyroid hormone, how calcitriol can normalize calcium. And FSH and LH, how that coordination, that dance, and you're going to go through some of the menstrual cycle basics to understand how important that is. But here's a connection. And again, these are just teasers. Thyroid hormone stimulating FSH and LH receptors on the ovary to produce progesterone. So what that means is we need optimal thyroid hormone in order to produce progesterone. This is why if we don't produce progesterone, we can have prolonged or painful periods or irregular periods, and this can be one of the mechanisms where thyroid hormone can be associated with menstrual problems. Now, you need to learn some of the subtleties here because the classic teaching is an underactive thyroid leads to no ovulation and no bleeding. And that can also be from a significant low level of progesterone, and there's no ovulation as a result. So you'll learn all the details of that. But just understand the takeaway here is this connection between the thyroid actually acting on the ovary. Insulin resistance causes androgen production. So this is something that I really didn't know or understand, and I'm not going to say I wasn't taught it. I'll just say probably I forgot it or didn't pay attention to it or didn't focus on it because I never really understood how PCOS worked, and you're going to learn a lot about the underlying mechanisms between PCOS. And you'll see that insulin resistance is the main underlying problem with PCOS. Not every single case, but that is far and away the biggest underlying issue. And I didn't know that having all of that increased androgen actually was caused by insulin. I didn't know that insulin caused androgens, and I didn't know, as you'll see, that sometimes androgens can actually cause more insulin production and leads to lower SHBG. So then you're going to have more free androgen, so that insulin, which was there producing more androgen, actually leads to more free androgen as well, and that's a double reason for that hirsutism that we see with PCOS. Another example is estrogen interacts with an increase in norepinephrine. So one of the things that can happen in menopause, in addition to this drop of estrogen, is a change in neurochemistry. And that changes the thermoneutral zone, or what we call the thermoregulatory zone, in the brain, and that leads to hot flashes and night sweats. So what happens is the body artificially thinks it's too hot or too cold, and therefore creates a sweat or a flash in order to cool the body down when the body doesn't need to be cooled down. So it's an inappropriate use of a thermoregulatory activity because of the combination of changing of estrogen, norepinephrine, and serotonin, changing that thermoregulatory zone. So when hormones work the way they're supposed to work, they're balanced. There's homeostasis. This is what we want as a practitioner to see in our patients. But as I said, it's complex. So what these incredible, I'll use the word athletes, are doing is something that's very complex because there's a lot of instantaneous changes in what their muscles need to do in order to maintain this position. It's a symphony of interactions. It's a fine-tuned system. And just like the orchestra, if there's one instrument that's off, everything is off. The other word I want to use for this, and there'll be another slide of this, but I just want to present this now, is balance. Hormones, when they're not working, you always hear your hormones are out of balance, or patients come in and say, my hormones are out of balance. And we talk about how when hormones are out of balance, it's usually because part of someone's life is out of balance. And I always discuss this with my patients, and I say it's going to be very hard for me to help put your hormones back in balance if your life isn't back in balance. And not only do and I always say, so you need to work on getting your life in balance. Now, of course, because I wear my hat of director of coaching, I don't say you need to work to get your life on in balance. I'm just trying to explain the importance of conveying this message to patients. And I always ask it as a question, etc. But for the purposes of this lecture, and because I get into trouble if I go over, I can't go into the details right now of how I do that. So I'm just describing it in a very prescriptive way. And so really it's about conveying the message that most of the work for me is about finding balance and creating balance here in the matrix. And most of the work for them, either if they choose to work with me on it, and I do see patients just for that, or I refer them out, or they're already working with a therapist or a coach. So there's work that has to be done on life, and then there's work that has to be done on the matrix. And my primary role, unless patients want to engage me in the other stuff, is balancing the matrix. So you have to balance life, you have to balance the matrix, and only then can hormones be in balance. And so when I say balance the matrix, this is what I mean. It means working with someone's genetic predispositions, understanding their traumas. You're going to hear a lot about the effect of stress and trauma. So it's about asking patients if they've been abused, and men get sexually abused as well. Physical abuse, sexual abuse, emotional abuse, ACE scores, what we call adverse childhood events, which can be the strongest predictor of physical ill health and morbidity and mortality. So understanding traumas, identifying nutritional deficiencies, making sure that we've identified problems at the bottom of the matrix, food, diet. Are they eating properly? Do they have issues with their gut? The 5R program. You can't, so what I say, and this is what I say as we talk about balance in life and balance in the physical body, and then as I'm going through everything, I say, your hormones can't be balanced unless your gut microbiome is balanced. And we talk about all the different ways that we can balance the gut microbiome. And we can't be balanced with our hormones unless our immune system is balanced. And so if there's inflammation going on in your body, or if you've got bad autoimmune disease, we have to try to do some root cause resolution there. And we can't balance your hormones if your mitochondria are out of whack. And that is definitely, I think, a concept that's going to be new to you, because now I'm telling you that steroid hormones are actually produced in the mitochondria. And there's actually thyroid has a big relationship to the mitochondria as well. So if we don't have mitochondrial health, if we have mitochondrial dysfunction, we're not going to have hormonal health or hormonal balance. Toxins. So environmental toxins, and there's all this literature with xenoestrogens and makeup and increasing the toxic load. Environmental Working Group, Keep a Breast Foundation, or has partnered with Environmental Working Group to come out with a list of the cosmetics that create the most hormone imbalance. So transport, if sex hormone binding globulin is off. So you can't have balanced hormones without balance in the matrix. The mental, emotional, and spiritual issues that our patients have or are confronting are in the center of the matrix. And again, can't stress that enough. So let's talk about PCOS a little bit more in detail. So we start off with insulin resistance. That's the most common. Yes, there are lean women with normal insulin levels that have PCOS, but that can be due to genetics, or it can be due to the fact that their insulin level, even though it's officially normal, may be too high for them. So we end up with this elevated insulin level, and that causes problems with the liver making less sex hormone binding globulin. We then have elevated LH secretion, and we make more androgens. So we end up with those elevated androgens, and guess what they do? They create visceral adipose tissue, increase free fatty acids, so that insulin resistance directly leads to elevated androgens. Those elevated androgens lead to more insulin resistance. And it's a vicious cycle. So what do we do about the hormonal soup? We take one step at a time. Most hormonal imbalance is complex. The way we address that is we go simple. So just like we've heard from Michelle Obama, when people go low, we go high. In functional medicine, when things get complex, we go simple. So we try to get information over a longer or bigger window of time, because I showed you how variable and how greatly hormone levels fluctuate. So it's not about a single lab result. It's a story of someone who always has breast pain and bloating month after month after month is different than someone who comes in and says, I've got some breast pain and this is brand new, that's why I'm coming in. I've never had this problem before. You don't try to treat everything at once. And so the challenge of coming to this course for a week is your head is lighting up with all of these connections that you never dreamed were there, and you feel like you can fix everybody and address every abnormality in the matrix. And I made the mistake of trying to do that in the beginning of my functional medicine career. And, Monique, I heard, went easy on me. But, we really, when I came back from my first AFMCP, we really did have patients crying in the hall after they saw me, because they now found out they had like 12 things wrong with them, 12 imbalances, and 50 different supplements to take, and they didn't know what to take, and it was a problem. So much so that one of my nurses, who was a long-standing nurse, thought that this whole functional medicine thing was crazy and ended up leaving. Because she's like, all you're doing is making your patients cry. So don't try to treat everything all at once. And you will learn tomorrow in the closing 2 sessions, which are wonderful sessions, about how to prioritize and figure out what to do. And the reason you don't have to worry about whether you pick the first intervention right or wrong is you always reassess and you always adjust.